Welcome back, everyone. Part 2 of our session, I think this will be session 19. So hopefully that previous one covered a lot of the operations of what goes on in the loop of Henle and collecting duct about water reabsorption and how we dilute and then how we concentrate our urine. It's actually quite an interesting process, isn't it? The loop of Henle concentrates that fluid in the interstitial fluid, and then that therefore allows the water to flow out and be reabsorbed into the bloodstream, provided there's ADH around. It is a tricky concept, and it does require you to go over it a little bit more, because most people don't get that process first up. And the way I usually try and explain it in terms of analogy is the loop of Henle has everything and nothing to do with water reabsorption. Everything to do with water reabsorption because it's the structure that's putting all the salts into the interstitial fluid to concentrate the interstitial medullary fluid. And nothing to do with water reabsorption because it actually doesn't do the water reabsorbing itself. It sets up the conditions so that the collecting duct can reabsorb the water, provided there's ADH around. If there's no ADH around, the water passes straight through and we pass it out in the urine. If there's ADH around, then the water can move out via osmosis down its osmotic gradient, which was set up by the loop of Henle, and be reabsorbed into the kidney, into the bloodstream, sorry. Okay, so next little section here is not too pressing. It's really how we look at evaluation of kidney function. And in reality, this is actually a very, very important thing that we need to do. We need to have a good idea of kidney function. Why is that? Well, if you think way back, I think in the first renal session, we talked about how the signs of kidney disease, so chronic kidney disease, doesn't really show any physical symptoms until you've lost about 75% of your renal function. So you don't actually start to feel quite sick. You don't start to show the rashes. You don't show the fluid retention. So you don't show a lot of the adverse signs of chronic kidney disease until much later on in the progression of chronic kidney disease, until you've lost 75% of your function. So that's why it's really important to evaluate kidney function, because you can actually pick up the signs of chronic kidney disease far earlier than that. So it's very important that we evaluate kidney function, because the signs of kidney disease come much later in the progression of the disease, and by the time you're showing the symptoms, you've already created a lot of damage to your kidneys already. So let's have a look at some of the terminologies and some of the things they do to look at kidney function. They look at your urine, so they look at the volume, the physical and the chemical properties of it, and they also microscopically look at it as well. They do urine cultures if they suspect a urinary tract infection. The other thing they do, as well as looking at your urine, is they take a blood test. And these are routine blood tests. So a lot of routine blood tests you'll see evaluate kidney function. Okay, if you've ever had a blood test done and you go back and have a look at the blood work, in terms of electrolyte counts and whatnot, you'll see that they've measured your GFR, or they'll call it the eGFR. One of the things they also test in there is your BUN levels, which is really a measure of your urea and nitrogen levels in your blood. And you may also find on there some things in there calculating clearance, where they integrate some of the results from your urine and integrate some of the results from your blood and calculate how is it that your kidney is handling things like sodium and glucose, and they express it as a clearance form. So that's just some terminology that they do go through. When they do look at your urine, physical characteristics of urine, probably everyone knows. Volume, so a typical volume in a day, so 24-hour urine production is about 1 to 2 litres. So above that or below that indicates some sort of process going wrong in the kidney. Obviously dependent on your water consumption, but if you're consuming a normal amount of water but excreting lots and lots of water, there's something wrong. Colour can vary, can go from quite clear right through to like quite a deep dark yellow colour, and that depends really on your hydration status. The yellow colour is actually a function of another bile pigment called urochrome. So it kind of goes all the way back to your red blood cells, doesn't it? We learnt in the GI system about stericoloban, which is a bile pigment in the faeces, and it's what makes your faeces brown, and that goes back to red blood cell breakdown. And it's also why your urine is yellow as well. It's a function of red blood cell breakdown. It's a byproduct of bile breakdown. Turbidity, so that's really how clear it is. It can go from very clear, transparent, right through to becoming turbid. The turbidity is a function of how it stands, and because of the ammonia that accumulates in the urine as it's standing, so it becomes cloudy when it stands. Odour, it says they're mildly aromatic. I certainly wouldn't describe it as aromatic, but all that means is it does have an aroma to it. Again, on standing, it generates an ammonia smell because the ammonium ions that are formed in the urine dissociate back to the ammonia molecule, and that's what gives it that ammonia smell on standing. Certain pathologies can be sort of hinted at with the odour of it, so diabetics have a fruity odour to their urine because of the presence of the ketone bodies. pH, as we said, is usually acidic, ranges from right down to 4.6 and can go right up to 8, but normally around the 6 range, fairly acidic. Specific gravity, this is really just a reflection on how concentrated our urine is. So the normal range is 1.001, which is very much like water, and it can go right up to 1.035, and that really just reflects the concentration of solutes in the urine. Some of the things they look for in urine that's abnormal, and these are some of the things that you can actually get dipsticks for now. They used to have to analyse them biochemically, but now there's a whole range of dipsticks where you simply put the dipstick into the urine itself and it'll analyse for all those things on that table there. So one of the most important things they look at in urine is the presence of glucose, so glucoseuria, and it's a strong indicator of diabetes mellitus. High blood glucose levels transfers to high blood glucose levels in your nephrons. Your nephrons simply can't reabsorb enough glucose because there's so much glucose in there. And because we do all the reabsorption of our glucose in that proximal convoluted tubule, once it's gone past the proximal convoluted tubule, it's now stuck in the nephron. There are no transport proteins to get it out. And essentially that's how the glucose appears in the urine. There's so much appearing in the nephrons aren't able to absorb enough out, and it simply appears in the urine. Some nasty things that appear in the urine, and they indicate indicate an underlying pathological process, is proteins. We learnt earlier on about the glomerular capillaries and how we had fenestrations, we had the basal lamina, and we had the filtration slits that were formed by those podocytes. Now, that's a selective filtration barrier, and it's selective for relatively small molecules. Water, glucose, amino acids can get through. Anything bigger struggles to get through because the holes are simply too small. So if you've got proteins appearing in your urine, it means you've got a damaged glomerular filtration membrane. So your holes have become damaged, your filtration slits are damaged, your basal lamina is damaged. So it indicates damage to the glomerular capillaries and that glomerular filtration membranes. So it's a really strong indicator that you've got a pathology going on, usually related to untreated hypertension, chronic kidney disease, or glomerulonephritis, or inflammation of your nephrons. Ketone bodies appearing in the urine. Again, that's a sign of diabetes. Diabetics are unable to use the glucose in terms of their cells are unable to take up the glucose, so it stays out in the bloodstream. And because the cells are starved of glucose, they use alternative energy sources, such as amino acids and fats. And this can lead to the formation of ketone bodies. It could also be a sign of starvation, so if you're really depriving your body, particularly of carbohydrates, your body switches to breaking down fats and amino acids and can, of course, create the state of ketosis. Some particular things you can have in your other blood are things like hemoglobin, where hemoglobin shouldn't be in your urine. If it does, there's something wrong with the breakdown of your red blood cells. Bile pigments can be appearing in your urine, and that's really a symptom of liver disease. Erythrocytes or hematouria. So when blood cells appearing in your urine, it's usually indicative of, again, a urinary tract infection or trauma to the kidneys, or kidney stones itself. So the trauma is related back to the kidney stones physically damaging the insides of your kidneys. And the other big one that they look for in terms of urine is the presence of white blood cells, leukocytes. And that's a strong indicator of a urinary tract infection. Okay, so as we mentioned earlier on, that they also culture urine and look for the bacteria that live in the urine. And there are a number of bacteria that grow in urine that indicate urinary tract infections, particularly those of the E. coli strain, and they're the ones that are normally responsible for urinary tract infections. Okay, so that's all about urine. Let's now just quickly talk about how we transport the urine that we've created in our kidneys, transport it down our ureters, store it in our bladder, and then urinate it out. So we're going to talk about how we urinate it towards the end. So urine transportation, storage and elimination. So as we've been talking about the kidney for so long, we've sort of really talked and finished talking about the collecting ducts as if that's where everything finishes with the nephron, and essentially that's true. So once we've gone through the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then once that fluid's gone down the collecting duct, there isn't anything done to that fluid in terms of reabsorbing any more water or electrolytes. So whatever's left in the collecting ducts is in fact going to be what comes out as urine. All that happens now is all the fluid from all the collecting ducts forms into larger and larger vessels that eventually leave the kidney in terms of leaving at the ureter. So from the collecting duct, urine drains into these structures called a minor calyces, and they form into a major calyces that then turn into the renal pelvis. And from the renal pelvis, the urine drains into the ureters and then down the ureters into the bladder. From the bladder, urine is discharged out to the environment via the urethra. So that's sort of what we'll go through now, is our ureters. So that's our first path. Where are they? Just like the kidneys, they're retroperitoneal. They're actually quite long, aren't they? They're 30 centimetres long. They extend from the renal pelvis all the way down to the bladder, and they sit posterior to the kidney. They sit posterior to the urinary bladder. So all that means is they come in and enter the bladder from the posterior wall of the urinary bladder. And you can see that from that picture there. You can see here's our two ureters from one kidney, ureter from the other kidney. They come in onto the posterior wall of the kidney, and these 2 points here and here is where they enter the bladder. So we actually have the entry point of urine that's been formed way up in the kidneys. It's come down the ureters and enters here and here. And you can see in this diagram here as well that we've got an exit point from the bladder through the internal urethral sphincter. Okay, and that forms a triangle that they call the trigone. So you've got the two entry points of the ureters, and the exit point from the bladder forms the trigone. Now, in terms of what the ureters are, we know they connect them from the kidney to the bladder, and they transport urine. And they do that not just by gravity. So you might think, oh, well, that just drains from the kidneys and it goes down into the bladder. Yes, gravity is on its side because it's flowing down, but it's also assisted by peristaltic waves. So this is exactly the same pattern of contraction that we saw in the gut that moves chyme and feces. It's the same pattern of contraction that moves or assists in the movement of urine down your ureters. Once those ureters join into the bladder, it essentially forms a valve structure. So as the bladder fills with urine that's coming from the ureters, the bladder wall, because they're coming in from behind, actually compresses the opening. Okay? So we compress the opening as the bladder fills, and it fills more because of the peristaltic waves. So as the bladder fills up, those openings close over, but flow is still assisted by the peristaltic contractions of the ureters. If anyone's had kidney stones, for example, they always describe that the pain of the kidney stones comes in waves. Those waves are the ureters contracting, and it's the pain of the kidney stones becomes really severe when the ureters are contracting and they're sort of pushing down on the kidney stone in the ureters. It's those waves which are the uretal contractions. Now, a little bit about the bladder. The bladder's a hollow organ. It's distensible, so it's very, very stretchy. It's lined with smooth muscle, and it has a capacity of about 800 mils. It's in the pelvic cavity, and it's posterior to the pubic symphysis. Okay, so that's our bladder. Holds about 800 mils. We talked about the trigone. It's in the floor. It's a triangular area that's bordered by the two ureteral openings and the one urethral opening at the sphincter there. So we talked about the opening of the ureters at the posterior point. The urethra drains fluid out of the bladder, and we have two sphincters, the internal and the external. If we go back, let's have a quick look at the two sphincters there. So we've just gone back a slide. So we've got a sphincter here, the internal urethral sphincter, and we have an external urethral sphincter. The internal is consisted of smooth muscle. The external consists of skeletal muscle. So the internal sphincter is under autonomic control. The external sphincter is under voluntary control. So we'll talk about that concept of the two sphincters, the micturition reflex or the urination reflex, and how they get innervated and controlled. Okay, so this is our urinating reflex, or technically it's called the micturition reflex. It enables us to discharge urine from the bladder. And what is it? It's a little bit like the defecation reflex, okay? So rather than pooing, we're peeing. And it involves activation of stretch receptors. We become aware that we have something in our bladder when the volume in our bladder gets to about 200 to 400 mils. The stretch receptors are stretching now, and we become aware that my bladder's getting full. Okay. When we decide that we want to urinate, a reflex is activated whereby we have a micturition centre in the sacral spinal cord. So it's a spinal reflex, and it's a sacral spinal reflex. So the sacral spinal nerves are right down the bottom in the last part of your spinal cord, and there's some interneurons and a reflex centre in your spinal cord that once those impulses are generated, it causes the detrusor muscle, which is the smooth muscle of your bladder, causes the detrusor muscle or the smooth muscle of your bladder to contract, and the external and internal sphincters to relax. Okay? So that's essentially how we contract the bladder, relax the two sphincters. But the key to the micturition reflex, of course, is we have conscious control over it. We can consciously control the external sphincter because it's a skeletal muscle sphincter. Okay? And we can delay the occurrence of that reflex by maintaining tone in that external sphincter until a certain point, and then we can urinate out. Okay, we can only do that for a limited period of time, so that's, you can only hold on for so long type analogy. Okay. As the urine's travelling out, it's got to travel down a structure called the urethra. Females have a very, very short urethra, 4 centimetres long. Males, in contrast, have a ridiculously large urethra. Why do they have a ridiculously large urethra? Mainly because it's got to travel through many, many structures in the male reproductive system. It's got to go through the prostate gland, through the muscles of the perineum, and then out via the penis. So the urethra actually has 3 regions. It's got a prostatic urethra, a membranous urethra, and a spongy urethra. So quite a long urethra in a male compared to a female. Okay. You can actually see the really short length of the urethra in the female. Here it is here, quite a short structure. We've got the urethra there, okay, and in the male you can actually follow it all the way from here, all the way down, back, around, and up through there. Okay, so there's our bladder in the male, has to come down the prostatic urethra, through the membranous urethra, and then down the spongy urethra. Females, relatively short, travels from the urethral orifice here up into the bladder. Okay. So, problems with urination is urinary incontinence. Okay. So it's a lack of voluntary control over micturition. And this is essentially toilet training in younger people. They need to learn how to contract the external voluntary sphincter. And it's not just a learning thing. It's also a function of the nerves innervating that sphincter as well. So not until about the age of 1.5 to 2 are the nerves fully developed enough to innervate the external urinary sphincter. So it's really a function of 1, neural development, and then learning how to control that sphincter. So that's toilet training in young kids, or 2 to 3 year olds. Also becomes a problem in adults related to stress. So this is related to injury of nerves or muscles or damage to a sphincter. And as we get older, things like abdominal pressure from coughing or sneezing or laughing or exercise, because of the lack of control over some of the sphincters due to nerve or muscle damage, can actually cause urinary leakage or urinary incontinence. So it's quite common as people get older, is that concept of urinary incontinence. So as we age, what happens to the urinary system? Renal function declines. So after about the age of 40, the effectiveness of our kidney function decreases with age. So you'll find that when you have a GFR of your blood, so when you have a blood test and they measure your glomerular filtration rate, it's called an EGFR. And the EGFR expresses your kidney function or your glomerular filtration rate, and it expresses it in a range such that it accounts for your age, height and sex. As you age, your GFR declines. So if you're a 20-year-old, your GFR should be around about 190 to 120 mils per minute. But as you get over 40, 50, 60, your normal GFR declines right down to, say, 60 mils per minute, okay? And that's normal. But if you're a 20-year-old with a GFR of 60, that would be abnormal. So it depends on age in terms of kidney function. That's all related down to how your kidneys shrink in size. And because they're shrinking in size, you're filtering much less blood. And the other thing that happens as you get older, and we sort of talked about this in the digestive system, older people become less sensitive to the dehydration. So even though they're dehydrated, they don't know it. They don't get that thirst of dehydration. So not only do their kidneys not work as well, but they also not realising that you're dehydrated as you get older. So one of the diseases that are common in the urinary system are inflammation or canaliculi, which are basically kidney stones. So kidney stones is a very common thing that happens within the kidneys or the ureters. Build up of oxalate crystals are the common one, which are the common things for kidney stones. Really just a function of pH imbalance in the urine, cholesterol imbalance. Many things can lead up to the formation of kidney stones, and it often has a very strong familial appearance. So if your mother or your father had kidney stones, you've got more likely to have them as well. Big problem, particularly for females, is urinary tract infections. So it's really a function of the anatomy of the female reproductive system, and also, as we just learnt, a function of the length of the urethra. It's a very short urethra. It's only very short. So urinary tract infections, because of the female reproductive tract anatomy and the short length of the urethra, make females quite susceptible to urinary tract infections. As we said before, retention or incontinence becomes prevalent. Nocturia and polyuria or dysuria. So nocturia is urinating a lot in the night. Polyuria is urinating lots. Dysuria is pain on urination. So polyuria and nocturia is usually one of those first signs of diabetes. When the glucose starts appearing in your urine, it has an effect of holding water in your nephrons, and you start to urinate a lot and get thirsty. Dysuria can be a function of a urinary tract infection, painful urination. And of course, the second dot point is very common for males. Males over the age of 50 tend to get an enlarged prostate gland. That's a function of the declining levels of testosterone. As the levels of testosterone decline, the prostate gland itself reacts and becomes larger. It hypertrophies. So there's benign benign prostatic hypertrophy. So that's just a benign enlargement of the prostate gland, and even when it's benign, it can cause problems in urination because the urethra itself passes through the prostate gland, and as it enlarges, it can constrict down on the urethra. It can become a real problem if the benign prostatic hypertrophy turns into a malignant growth, and that's prostate cancer. The last dot point there, diabetic nephropathy, that actually is now becoming more and more common because of the prevalence of diabetes. The high glucose levels that are in the blood for long periods of time cause severe amounts of damage to many very fine blood vessels. So this is why we have glaucoma and the blindness associated with diabetes, because it damages those tiny blood vessels in your retina. You have the function of damage to your glomerular capillaries as well, because these are very fine, delicate structures that are damaged by the oxidative processes that happens with the high blood glucose levels that are in diabetics' bloodstream. Okay. So that gets us to the end of that session on how we urinate and transport urine and then eliminate it. When we come back, we'll finish up talking about just some big picture stuff about fluid balance and acid-base balance, and that'll be the sort of finish up of the renal system. So we'll see you in that last